We can sit down.
Now, I would describe baseball pitching as monotonous. Monotonous meaning it's the same motion repeated over and over again in the same direction, as distinct maybe from handball, where you may be blocked by an opponent and you may be throwing the ball somewhat differently. And the reason I bring it up is the classic test for instability in the throwing athlete in the United States is what's called the milking maneuver. The milking maneuver is a moving valgus stress test with the arm at about 60 degrees through an arc of about 60 to 90 degrees of flexion, where you apply a valgus load. And that seems to isolate the anterior band of the anterior bundle. But Dr. Popovich, in your study, you looked at valgus stress in almost full extension, and I was wondering whether you think there are any differences in the two.
I have it here. What I would like to explain you on the end of your question, valgus stress with the stellar stress device is at about 30 degrees of flexion of the elbow. That's a little bit when I think medial collateral ligament take from bone structure importance of stability. Second thing, when you compare baseball and handball, that's true. There is some difference because the ball in baseball is smaller than ball in handball. And there is also that handball is contact sport, and sometimes in the matches you have throwing motion with resistance, who is very, very dangerous for the player when they go and in the last, in the acceleration phase, if they are blocked by other player. But what was my intention? To, as you saw, colleague, when he say number of arthroscopy in France, France is champion of the world. That is, there is much bigger community who needs. There is much bigger community of athletes who should be treated that we missed because they are not aware that that is beginning of the end of the normal elbow. That was my intention.
Thank you. Had a question?
My question to Dr. Popovich. You mentioned obviously the very high incidence of what appeared to be pathologic changes in imaging in particular, and yet a couple of times you pointed out to us that the athletes were saying that there's nothing wrong with their elbow. Does this mean that there's a high rate of false positives with our imaging and our investigation with these guys?
I didn't have time to complete my my epidemiological study, but in my epidemiological study, on the question, who did you consult for the problem of your elbow? What was the response? 30% of the athletes told nobody, and only 9% of the athletes had response that they consult a doctor who is specialized in the elbow. That means still in this community of sportsmen, this problem is underestimated on the base of my, and I was one also.
My impression, can I interject? My impression is that it's a tough group. These are tough guys.
Yeah.
They don't complain much, one. Two is maybe the mechanics are a little bit different, and I'll give you the example in the United States. We had a very high-profile American football quarterback rupture his ulnar collateral ligament, and he did not have surgery. He did not need surgery. It was a complete rupture, documented. And the mechanics of throwing are a little bit different, and he was able to get away without an operation, whereas a professional baseball pitcher would be out without surgery. Yes.
Good morning. I'm Dr. Riyad Magdassi from Hamad Medical Corporation. Now, my question to Dr. Luigi, if we go through the anatomy, the LCL, the lateral collateral ligaments, are the least components in stabilization and extension and inflection. Now, and the MCL gives more share, and the bony congruity, of course, are more, especially in inflection. Now, my question is, in close dislocation of the elbow, do you always, or when you would repair the lateral components, the tear and the lateral collaterals?
Well, I think it will be in the next presentation by Francois, but it doesn't matter. We know that in luxation there are different degrees, and you have stage 1, stage 2, stage 3, A, B, C. So the lateral collateral ligament is the first that can really go broken when you have a complete luxation. So what I do, my personal, it is something that is connected to some other question about the topic we will discuss now. My practice is that if I have no broken bone, just luxation, I bring the patient under anesthetic, and I put the elbow back in a good position. Then I test, and I put the patient in a back slap for 3-4 days. Then I test the patient again. So if I have a single rupture of the lateral LUCL, I don't go for repair. And then I have a look after a week. And after a week, I understand better if it's still a bit unstable or not. If I go for medial, I have a look on the medial side, immediately under anesthetic. I reduce the patient under anesthetic. I'd not like to reduce the patient without anesthetic. You can break the radial head. It happened in my department twice. And then if it depends, of course, from the age. It depends from the functional habits of the patient, if he's a sportsman or not a sportsman, if he's old or not. But if I had to do a radial head, maybe fracture, I always go to repair also the medial collateral ligament.
Your question was about the lateral collateral ligament, that's right? Or
yes.
The medial?
Yes. No, so I mean, in dislocation, in simple dislocation, it's the MCL is almost, according to the literature, it's almost always a stone. I mean, but the LCL is less than that. There is some controversy. I mean, there are some different studies, but most of it, they will insist on MCL tear is more than the LCL tear. I don't know whether...
You're perfectly right.
Yes. So if it is unstable, as Dr. Luigi said, in general anesthesia, you test for it. If it is unstable in less than in less than 60 of a flexion, then you may have to go for repair. If it is in less than sorry, in more than 60 of a flexion. In less than 60, it will be unstable. Then you have to go for repair. But if you will go for repair of the MCL, would you need to go for the LCL?
Never.
Yes.
About the LCL.
Yes.
About the LCL, never at the first intention.
Yes.
Okay.
It will be my lecture this afternoon about first-time dislocation.
This is a great segue into this afternoon's series of lectures, and probably the most controversial topic that we will discuss at this meeting. So we can do battle this afternoon after we have these lectures. Any final questions before we take a break? I think we have time for one more. Yes. The mic is coming your way. Hang on one second.
Thank you, everybody, for these nice lectures. For Dr. Kelberin, we are happy to see you again for the second time. And my question is for you, Dr. Kelberin, is when you, before doing this, doing your surgery, do you have in mind that you will make an anatomical repair or function restore? And it means if this elbow, it's dominant elbow or non-dominant elbow, is difference in the repairing, or if this elbow for a gymnastic one that will throw and make like weight bearing, and for the guy who throw is it means you don't have any difference in the approach of the late function, specific function of that elbow, or it's same repair just for restore anatomical problems and that's it?
In fact, the function is the consequence of your anatomical status. That means if you have an elbow unstable, if we talk about dislocation, if you have an unstable elbow, you can be athletes or not, you have to make it stable. Of course, the purpose in high-level athletes who are weight-bearing or in axial loading and so on must be perfect. So that's why, but it didn't change my way of treating the patient. I treat the same way a patient which is a high-level one than a non-high-level one. But the aim is to make a stable elbow. So you have slight instability, which is not acceptable in the everyday life for us. If you just want to rise from your chair and each time you feel your elbow just slightly unstable, it's not acceptable. And of course, it's much more detrimental for the high-level athletes than for the normal population, but it doesn't change my way to treat the patient.
Okay, thank you. Second one is just one small. It's the loose body, when it disappears for months and comes again. Where did it go?
Everywhere.
Yeah, I know. Really.
When you lose the loose body?
No, they don't. The athletes feel the loose body and then doesn't feel it for 3, 4, 6 months.
It just got in the recess, it just embedded in the synovium under the triceps.
For months.
Yeah, for months.
So it's
for
better
months.
to take it off.
If it's locked, yes.
Yeah. Thank you very much.
Well, those are some great questions. If we can head out, give these guys a hand, first of all, for their terrific talks, and head out to the atrium where we have coffee, and we will reconvene at 11 a.m. Thank you.